Good afternoon, respected teachers. Myself, Dr. Yogesh. I am from Usmania General Hospital. So I am presenting a short case. So my patient is a 51-year-old male patient, Srinivasulu. He is a resident of Hyderabad and driver on private vehicle by occupation, and he studied till 8th standard. So history is given by himself and his wife, and it seems to be reliable. It is a known case of hypertension and CKD ESRD on CFD for the last 4 years. And he mainly presented with chief complaints of fever with chills with poor outflow of TD fluid or fluid since 4 to 5 days. So I would like to take back my history in 2019 when he was 47 years old. So he had developed incident onset of pedal edema, which was gradually progressive. Initially it was confined to the ankle actually, which progressively increased up to the knee joint. Then it was treated with dyspnea of grade 1, NYHI class 1. Patient for the same reasons actually patient consulted a local hospital where actually he was prescribed some medication and diagnosed to have hypertension. He was also advised to undergo few blood investigation which he did not follow. His symptoms deteriorated over the next 2 weeks, and gradually he developed facial puffiness and abdominal distension also, and his grade dyspnea increased from grade 1 to grade 3. He also complained actually having dyspnea on lying down position, and he also complained he had 2 to 3 episodes of midnight awakening actually because of the breathlessness. Okay. On direct questioning actually he told actually he also had a oliguria, but there was no history of any urine, hematuria, dysuria, gravenuria, lower urine tract infections. No history of any chest pain, palpitation, exertion, angina. There is no history of any enlarged discoloration of the eyes, abdominal pain, pale stools. No history of any fever, rash, arthralgia, sore throat prior to these episodes. So for the same complaints, he was admitted in NIMS hospital in 2019. On evaluation, he was told actually he has small kidneys and some heart dysfunction also. So he was initiated on hemodialysis. He underwent almost 4 sessions of hemodialysis, following which he was given option of CEPD because of his heart condition. So he underwent CEPD catheter insertion after stabilization by open surgical method, and meanwhile he was given hemodialysis, and break-in time was almost 14 days. He was trained for the CEPD catheter exchanges, and he was discharged with prescription of 3 exchanges with 2.5 liter of dextrose with well volume of 2 liter, and well time was 6 hours. So he was doing well actually, and his CEPD prescription was changed from 3 to 2 in view of his better condition and decreased edema, and his genetic urine output also increased to 2 to 2.5 liter. So in July 2020 actually they observed actually he had a very good output and clinically he was doing well, and he was told actually that creatinine is less, but value he doesn't remember, so they stopped actually peritoneal dialysis for the next 4 months. Then again in July 2020 he presented with uremic symptoms. His creatinine was elevated. Again restarted actually on CAPD, exchanged with 2.5% dextrose, 2 exchanges with 2 liters of dwell volume and 6 hours of dwell time. His ultrafiltration that time was 900 and urine output was around 2 to 2.5 liter. Patient was doing well from July 2020 to 2023. He was compliant to the salt and water intake, and his PD ultrafiltration was urine output, native urine kidney output, and he never had any hospital admission there. And he was taking erythropoietin twice a week, and he was taking iron injections once a month. He never received any blood transfusions during that time. 1 month back, patient unfortunately met with an accident while coming from his son's marriage function. On direct questioning, he told he had impact on the hip joint, but no direct impact on the abdomen. He was immediately taken to the hospital, and after primary evaluation, actually he was discharged on the second day with the medications. 4 days later, he noticed actually he had a cloudy PD effluent, and 2 days later he developed fever with chills. For the same complaints, and he also told actually there is a poor outflow from the PD catheter, and he told actually it was taking almost 2 hours actually to for the outflow to come around like 1 to 1.2 liter, with the dwell being actually 2 liter. So on direct questioning, he is told actually there was no change in the aseptic precautions, or no change in the caretaker, no change in the PD bags, or no history of any giddiness, nausea, vomiting, no history of an exit site, tenderness, erythema, or any post discharge. He was admitted at NIMS. He treated with intravenous antibiotics and antibiotics. Blood investigation culture also were sent, but he was not aware about the reports. After 10 days, he got discharged. With the his condition became better, and feeding catheter outflow also improved. With the retraining, again he developed similar complaints after 10 days actually, and again readmitted. Currently, patient is being shifted on hemodialysis. With he underwent almost 3 sessions of hemodialysis, and CPD has been stopped temporarily. So this is my HOPM.
Stopped with catheter in situ or catheter?
With the catheter in situ, sir.
Stop.
Yes, as of now.
Okay.
Why was it stopped? Any particular reason? Or just low outflow was the reason?
No, sir. Actually, this time actually outflow has significantly decreased. So because of that reason, and second thing is actually he is having a lot of pain actually while yeah.
Ongoing infection, ongoing peritonitis, or
Looks like an ongoing peritonitis, or could be. No, sir. Actually, he had improvement, so could be like a relapse or a recurrence of the peritonitis.
peritonitis now?
Yeah.
Ongoing relapse or recurrence or no?
The cloudy effluent cleared and then again became turbid, or what happened? Any turbidity in the
Again, this time again he developed the same complaint, but this time actually the flow dysfunction is too much. He is getting around like 3 to 400 ml output, and pain is severe, sir, this time.
So both factors,
Uh-huh.
recurrence of the infection and poor output
Yeah, sir.
and pain.
Yes, sir.
So what would be the ideal things to do?
In this scenario, sir.
What is the recommendations how to approach this patient?
Sir, ideally, a patient, if they are having a recurrent or relapse of the peritonitis, it's not a direct or absolute indication, but it's as per the ISPD guidelines, sir. But we can think about actually change the catheter because he's having a recurrent infection, and there is a catheter dysfunction also. And
What is dot in ISPD guidelines? Where is the dot? Why it should not be removed? If the patient has relapsing peritonitis happening,
so they say actually refractory peritonitis is a absolute indication to remove it and harden it.
and this patient came within 10 days.
Yes, sir, within 10
Within
days.
10 days. So
Yeah.
this is little like more of the relapse or recurrence, or both are different.
Uh, we can't say, sir, actually, unless until we know the culture report. So that
Organisms.
organisms, yes, sir.
Organisms.
Yeah.
So which is more common? Relapse or recurrence?
Relapse is more common, sir.
Relapse is more common. So why they are relapsing more common?
Especially
Why there is two different things. Relapse and recurrence are two different things required for the practicing purposes. Why both are required? Relapse and recurrent are different.
why it is different, sir? Because few organisms are very difficult to treat, sir.
Why relapse happens?
It is mainly because of the organisms, especially like Staphylococcus aureus, which is very difficult to eradicate. Second is actually if it is like a fungal infection, because of that. And third thing is like because of the
Why will it
Antibiotic.
becomes difficult to eradicate? The most important question, I agree with you, difficult to eradicate. Why it becomes difficult to eradicate? One liner answer. Well, despite giving you stronger antibiotics, the patient do not responds, but again it comes out. So,
because
formation of
biofilms.
biofilm formations,
or a tunnel infection.
or associated with some other infections. Because the patient went and coming back. So, putting the catheter in the C2 and then shifting the patient on dialysis. So, do you think this is going to eradicate infection or remove biofilm?
It is very difficult to eradicate biofilm, sir. And at this time, for this patient, it is
Even
better
you
to.
cannot do if anything instrumental or investigational things going on to break this biofilm, then it is fine. Otherwise, it is difficult to do. So, how we diagnose peritonitis?
how will you diagnose? Depending on the clinical signs and symptoms, especially with the patient having abdominal pain, tenderness, and fever, along with actually the patient's if the CD cell count actually showing WC count more than 100, with the differential count showing more than 50% polymorphonuclear cells, and culture positivity, from PDF lab.
So that's no. ISPD guidelines is 3 criteria. Out of 3, 2 should be there. So,
Yes,
what are the criteria? Tell me.
One is actually clinical signs and symptoms. So
Signs and symptoms of inflammation will be there with along with TB.
second is actually like the cell count actually should be more than 100 actually with a difference of more than 50%. And culture has to be positive for culture positive. If it is culture negative, these 2 criteria if it is met actually we can diagnose as a culture negative.
Third criteria is isolation of organisms, either on the culture or on smear. When sometimes you send it for the smear, they will report it, there is some fungi even on the gram stain. So that gives you the clue, there is some organism isolated. So isolation of, sometimes the AFV comes on this, sometimes the gram negative SLI will come on the smear. So that gives you isolation of the organism either on smear or on culture. So 2 out of 3 will give you, satisfy the criteria of the diagnosis. So why these 100 cells are taken into consideration?
In SPP, what is the criteria?
250, sir.
250.
What-
So why is it low here?
Because of higher risk of
No, because you are draining the fluid every few hours.
So everything is diluted with the normal PD fluid, normal PD fluid. So that's the reason why this is taken. Suppose your patient is on APD, automated peritoneal dialysis. You have to diagnose peritoneal dialysis.
sir, in that case actually the total count doesn't matter. Even if it is less than 100, it is can be diagnosed if the differential count is more than 50% polymorphonuclear cells, neutrophils.
Or you prolong the dwell time and then see.
You can stop, you can go back on this conventional can do, but for APD some suggestions came out of some consensus decision. 50 cells and since the response is more than 50% neutrophil, you can take consideration that idea. So scenario becomes little different. So based on your whole your history and examination, what is your diagnosis, provisional diagnosis?
Sir, the provisional diagnosis is basically CKD SRD on a CAPD. Maybe he is having underlying CRS.
Use the term of G5 rather than ESRD. That term is obsolete.
Then cardiovascular syndrome, underlying pathology, cardiovascular syndrome. My syndromic diagnosis is CKD G5, and the probable etiological cause could be like a cardiovascular syndrome or a CKD CIN, and along with actually patient has a
You
peritonitis.
said cardiorenal syndrome, then why could you again say CIN?
Second possibility I am keeping.
Second possibility.
Second possibility.
Second possibility.
And then the hypertension, anemia, and with native kidney output of 2 to 2.5 liter, relapsing or a recurrent peritonitis with a catheter dysfunction.
Even when you use the term cardiorenal syndrome, it's always better to qualify. Are you talking? There are 5 cardiorenal syndromes. So
Which
one?
type?
Is it acute? Is it chronic? Here, obviously, you're talking of chronic. You're not talking of acute. But then you need to specify, and then you also need to specify what is the chronic cardiac condition, what is the chronic kidney condition. Only then it's complete. Otherwise, it's incomplete.
Why do you
Sir,
think it
this
is
patient,
cardiorenal syndrome as the cause of his renal disease from this history?
Yeah, ma'am. So initially, basically, he started with fluid overload signs symptoms, and he had a history of orthopnea and some 2 to 3 cases of PND. Later, actually, he developed renal symptoms in the form of aloe which was for 3 to 5 days only in 2019. So that time only he was told actually he has some kidney issues and heart issues, and since then actually he was on dialysis. So it is very difficult to make out as both condition diagnosed
He was suggested
together.
CAPD. initially itself, isn't it?
Yeah.
That may be one of the reasons to think in terms of a significant cardiac failure.
And that may be the reasons for actually telling type
What are
of
the other
cardinal
indications
syndrome.
for CAPD as the first mode of CART?
Sorry, ma'am?
Other indications for CAPD as the initial mode of care.
Pediatric patient, any patient having hemodynamic instability, ma'am. Then if the patient, if we want to preserve the residual renal function,
Everybody wants to preserve residual.
Everybody wants to also.
No, not to preserve.
Others are
multiple access failure.
HIV infection. You want to avoid keeping those patients. It's a rare problem now, but you want to avoid keeping them in the hemodialysis unit. So therefore, that could be one reason, and of course, one
Patient has no access.
Multiple access failure.
multiple access. But that will happen with a patient who has been on hemodialysis for a long time. It won't be a primary CAPD. And of course, one issue we discussed yesterday was cirrhotics with ascites.
Bedridden patients.
Bedridden patients, another one.
At one end you are getting the diagnosis of the CRS, other end your second differential diagnosis is CIN. So how this CIN is associated with this cardiovascular syndrome?
And he has switched over to hemodialysis now.
Yeah, present.
So what are the special concerns when somebody on CAPD develops CAPD peritonitis and you are switching over to hemodialysis?
So
What are your special concerns?
the most important thing is if the patient is because of the ongoing infection actually he may not be hemodynamically stable, and during hemodialysis actually they have a higher chances of developing intrahepatic hypertension.
Increased chances for cardiovascular morbidity and mortality. It is a very well-known fact. It is a hot topic. Please speak about. How do you explain this? So, any person who is switching over from CAPD to hemodialysis after a complication of the CAPD peritonitis, they have to be extremely careful in handling those patients in hemodialysis unit. They are not the routine run-of-the-mill patients. They are highly vulnerable for hemodynamic instability and cardiovascular morbidity and mortality. So much so that currently the definition of CAPD peritonitis related mortality, death itself is redefined. Any death happening even after 1 month after the episode of peritonitis, it is included under CAPD peritonitis mortality, and this death is cardiovascular death. The reason is that already CKD is a state of tremendous inflammatory load. On top of it, an infection like CAPD peritonitis, suddenly there is increase in the inflammatory burden that leads on to oxidative stress, and that works so badly on the heart.
So here the switching to hemodialysis, is it only temporary
It's
because of
temporary.
the outflow failure, or is it
Means
long
they are
term?
planning for permanent access actually and convert into HD.
HD.
If the patient is insisting on reinitiation of CAPD, when will you reinitiate?
For this patient.
Catheter removal after a assistant peritonitis.
After 2 weeks actually, provided actually after 2 weeks of removal of the catheter, provided actually the culture has to be negative and the cell count actually again should be less than 100.
2 weeks?
2 weeks then? Okay.
Is that
Yeah.
enough?
Why this biofilm with this bacteria is there in the abdomen? So that is the most important thing. So that needs to be removed. First of all,
After catheter removal, then reinsertion can be
trial after how many weeks?
Many weeks.
What is the general recommendation? If you don't have the organism,
At least 6 weeks.
you have organisms isolated?
Sorry?
You have any idea of organisms isolated? No. So in that scenario, what you do? If you have some organism isolated, gram positive in which group? How many weeks you should wait for? Pseudomonas, Staph aureus, other culture negative peritonitis, and all. So many times you might have the simple culture negative peritonitis. You might not be able to get.
What is the prevalence of culture negative peritonitis now?
in India, ma'am. There are different studies actually, but cumulative incidence is around like 60%, ma'am.
60.
60%. Even like
No.
one
What
study
ISPD guidelines say? What is that?
Yeah.
it should be less than 15%.
Initially, it was recommended that it should be all centers should have less than 20% of all episodes of the peritonitis. If there is more than that, they should try to investigate why there is so higher culture negativity. So that is the usual recommendation. But culture negative rate in India across that one is Indian peritoneal dialysis has tried to evaluate. Really, that was very high, approximately going to 40-50%. Initially at most of the centers because of the wrong techniques. So suppose you are going to establish your PD program, you have to develop microbiology colleagues might not be knowing about the peritoneal dialysis. They will ask you what to do. Always coming culture negative
How to
peritonitis.
improve the
How to
culture
improve the
positivity.
How will you improve the yield?
First thing, collection of the methods. The collection has to be like should be taken actually in aseptic precautions. Almost 10 ml of
So here is the cash. This is the reason why it is 60%.
ideally we should send actually the whole bag actually.
Ideally the whole bag or at least 50 ml.
50 ml.
Or at least it should be 50 ml. Tell me that.
Then other methods like we should use the other automated methods which will yield the more such as backtake methods.
Automated method तो सबके घर में भी हो सकता है. They can take this here, but that is not this situation. So which part of this you will try to culture? How will you do culturing process? क्या होगा? What will be the culture process?
Ideally actually the guidelines actually we should repeat the culture on first, second and third day. If it is negative, it is called as negative.
So I have just given you a hint about the microbiologically. They do not know about this PD fluid processing. So you will do centrifuge this. Whatever you do, either large amount 50 ml if centrifuge allow use. If it is not, then even 10 ml can be centrifuged there. You have to get the sediment. Sediment should be inoculated for the culture on the culture plate for both aerobic and anaerobic. So that is the usual. If you will not do that, then actually this is not the normal body fluid sending you for the culture. Like the peritonitis, general peritonitis, you can take 10 ml and you can send it because this is diluted in the normal PD fluid. So you are sending the culture, you have to develop this process. So if you will not do this, the yield will always remain less. So this is the usual, and then you can definitely yield is relatively better than sending like as such 2 culture bottles having little larger amount like the 10 ml in 2-3 bottles. That is also but this is not the ideal process. The ideal process is to do centrifugation, take these sediments, then put these sediments on culture media. So that is the ideal process. Otherwise it will be negative. So
How do you conduct an audit after an episode of COPD peritonitis?
There should be a regular surveillance actually whenever for the peritonitis to know the peritonitis rate. We should call all the technician, the nursing staff, and we should find out actually the possible reasons.
So from nursing staff and people, it happens at home. It's not hemodialysis infection. But your COPD peritonitis, how do you investigate it? Each episode of peritonitis, we are supposed to conduct an audit. How do you conduct that audit? Simple questions, simple few questions. But information you would like to know.
What is the usual cause of a peritonitis?
Mostly it is because of the unhygienic handling of the
Change in hands. Change in hand.
hygienic that is very broad one. So that does not fit into your explanation. So what unhygienic condition? What is that called? Unhygienic condition. Touch contamination. So that is the usual words used for this peritonitis.
You have to retrain the catheter.
Yeah.
Retrain the catheter. supervise, and the history of recent diarrhea, GI infection, recent urogynecological procedures without antibiotic prophylaxis. All these are things. Unless we do an audit, the mistakes are likely to recur.
What are the different ways of the transmission of the organism into a dental cavity?
It could be like intraluminal, periluminal, sir. Then third could be like from the GI tract.
Transmigration, that is called transmigration of the organism. That's why incidentally you have to ask about the diarrhea, recent issues of the diarrhea, and sometimes hysteroscopic examinations, that leads to so you should have the audit, really the change in the caretaker, that becomes very important. How you have done, that should be repeated before your trained nurses, that are really are steps. Over the times, the caretaker becomes fatigued. They stop doing whatever you have taught. So,
Before an endoscopy or something like that, what should you ensure?
First thing is actually we should ensure that patient should receive a prophylactic antibiotic, and then second thing is before doing any procedure, actually the all the PD effluent actually should be emptied.
Dry. The abdomen should be dry. That is the most important precaution, even more than the antibiotic.
only last question, sir. Why you have put your differential diagnosis of the CIN when you are making the diagnosis of cardiorenal syndrome? So you should take precautions of making such a differential diagnosis. Cardiorenal. Yeah, I am not telling you anything that great, but whatever you make the differential diagnosis, you should think of why I am making, what are the points in favor, what are the points against this. So that will make you wiser. Otherwise, how the patient of the CIN will develop this cardiorenal syndrome, which is common.
And what is the commonest type of cardiorenal syndrome that you encounter?
It is the type 2, sir.
Is it?
Type 1.
Type 1, no.
You are talking
Most
of
commonly
acute
what we see.
cardiorenal syndrome.
But only cardiologist saying very carefully.
Yeah, so that's
Type 1 is for cardiologist.
Yeah.
Cardiology, 3 and 4 is
so you don't
Always
get
see
CKD with that.
CKD, CVD, no?
You don't get CKD with that. No? The next commonest is CKD associated.
Type 4.
Yeah.
Type 4.
That is the commonest after
It
this.
should be renocardia.
Yes.
Third and fourth is renocardia. Remember,
Yeah, which is renocardia.
Cardiorenal, there is a type 1 and 2.
Very carefully.
Remember in that way.
So when you talk of acute cardiorenal, it doesn't cause CKD.
Okay.
AKI usually, most of the time it will be AKI. So that's why to fit that diagnosis also is not really justified. Unless you are sure, don't commit yourself to that.
और इतना fascinating diagnosis बनाने की जरूरत
हाँ,
नहीं. You can get out of this.
The two things could be separate, entirely separate.
You can explain everything in this hypertension body model.
Yeah, he had hypertension, there's this 4-year history, small kidneys, you have all that.
CKD, body normal, what can have issue.
So the cardiac problem could be under it.
Most of the patients had cardiac problem. Have you seen any patient? 80% of the patient had CKD, had hypertension. Hypertension is a cardiovascular problem. Those who have chronic hypertension would have the left ventricular hypertrophy. So that is almost universal. So only 10-20% patients are left without hypertension. So this is truth, this is fact that we do practice. But you should know about all these facts, how you are going to explain when you are making a diagnosis. Okay, that's all. Great, thank you.